Good morning and welcome to the third and last day of ICPLP 2021. As usual, please ask all your questions on Slido using the code 635252. I repeat, 635252. And then we'll take all the questions after the workshops and ask them to the presenters. And with this, welcome Dr. Lester and her colleagues for their workshop on peripheral nerve stimulation.
Thank you, John. My name is Dr. Denise Lester, and I'm from the United States, from Richmond. I'm one of the pain physicians, anesthesiology trained and addiction pain trained, here with a wonderful team from USA. It's Dr. Brooke Trainer, anesthesiologist, intensivist, pain management physician. Dr. Robert Trainer, anesthesiologist, addictionologist, pain management, too many titles. Dr. Doug Murphy, who's also our amputee coordinator across the eastern side of the United States, and Dr. John Hermansen, who's our pain fellow, working with us for the year, learning about pain and interventional techniques for pain. So basically, I am so excited to be here. We are doing lots of peripheral nerve stimulation for our patients. In fact, we are the #1 implanters in the United States right now for peripheral nerve stimulation for a myriad of disorders: chronic pain, cancer pain, acute pain. Even Dr. Trainer did 6 peripheral nerve stimulators in one patient with Guillain-Barré. So the future is just wild. We're excited about it. This little teeny string here that you can barely see, I don't know if he can show you or not, this little teeny string, this little thing, like a dental floss, is helping patients with phantom limb pain and stump pain bring their lives back to some normalcy. So I've got to start off with a joke, because that's what I'm supposed to do in the beginning. So, as you know, I have my grandfather, great-grandfather, his great-grandfather are all from Sweden. I am Sweden born and bred. Now you're all saying, really, really? I'm like, no, no, no. So the joke is, you ready? Ready for it? She's ready for it. What do you call someone like me who pretends that they are Swedish? Anybody? Anybody? Artificial sweetener. Get it? Oh, there you go. So they're going to get some sweetener today for your coffee. All right. That's the one and only joke for the morning, so bear with me. So basically what we're going to talk about, we'll do the next slide here so we can get started here. Basically what we're going to talk about is our experience with peripheral nerve stimulation at our hospital over the past 5 years. I will disclose that we are all investigators in studies looking at peripheral nerve stimulation for amputation. Those studies have been sponsored by the Department of Defense as well as SPR Therapeutics. We also are investigators for spinal cord stimulation for locomotion in paralyzed veterans. So we do disclose that those are all grant-funded studies that we participate in at our hospital. All right. So my role is to review the history of peripheral nerve stimulation, and the agenda will tell the other things that the other speakers will be talking about. I'll let you see that in a bit. So what is this? This is a torpedo fish, 2,000 years ago. So this is not a new concept. Electricity removing pain is not a new concept. 2,000 years ago, 15 AD, Scribonius said, I've got this gouty knee, it hurts all the time. And when I swim, it feels better. So he's swimming, and all of a sudden this huge torpedo fish lances on his knee, shocks him, and he has pain or pain relief. Pain or pain relief, you can vote. The answer is yes. He had pain, but then he had this phenomenon where the pain went away for a long period of time. And he got so excited, he called his friend Hippocrates, said, hey, Hip, come over here. We need to do this for many, many, many patients. We need to put the torpedo fish at the knee for gouty arthritis. We should put it on the head for headaches and put it here for protracted anus pain. I don't know why he picked those 3 places, but he did. And patients were getting relief of pain in lots of places from electricity. And that was the birth of neuromodulation. Electricity, changing sodium, potassium, calcium, letting nerves lie asleep rather than awake. All right, so that was the very beginning. And then many things happened from that point. The very first piece of equipment that used electricity to treat pain is called the electrete. Place it on the patient, it shocks the patient, and then the patient had pain shooting in, pain shooting out. That was the first thing. All right, in 1884, there was the first intraoperative use of electricity and occipital encephalophilia. All right. Some of our workers in the field of pain that we must note, Wall and Melzat. So Wall and Melzack, they wrote the first paper that looked at the pathway of pain differently. They said that it's not that pain is a line. I hit my finger, it goes to my spinal cord, my brain. But there are a myriad of things that happen to influence the pain experience. They found that when they stimulated their own infraorbital nerves, they had pain control from electricity. So you knew that it could be manipulated, and they thought that this was the beginning of the idea that pain is not just a single path in the brain, but it has multiple variables. This Sheldon was the first to implant peripheral nerve stimulators surgically. And then Hasselbach did 30 patients with peripheral nerve stimulators for complex regional pain syndrome. And he had very good results out past 6 weeks. And this is the same timeline. The biggest thing in peripheral nerve stimulation were related to two different doctors, John Shea on the left and Mark Huntoon. What John Shea did was he took patients with stroke, hemiplegic shoulders. They had pain, and he placed 4 leads surgically in the muscles surrounding the joint on one patient. And the patient did well for weeks and weeks and weeks. And he said, well, wait a minute, if I do that, can I do it with one single lead at the axillary nerve? And he did that. He did that for 60 patients. And he randomized them to sham versus not. And what he found out was 4 years later, after 6 weeks of stimulation, they still had pain control. They still subluxed, but they had no pain. That was a big difference from the patients in the sham group. So when that happened, Dr. Mark Huntoon said, well, a surgical procedure to place this tiny little lead is a bit much, right? I've got to trial the patient first for 3 to 7 days. That's an operation. Cut open the skin, cut open the muscle, lay the lead on top of the nerve in direct vision, close it back up, and then see if it even works for 3 to 7 days. Wait, open them back up, put the permanent lead in. Very invasive, very aggressive. And sometimes the trials just didn't work, so now the person had this major surgery. But Dr. Huntoon was already familiar with using ultrasound to place needles for pain. So he said, what if we did the same exact thing, take that little lead, but no surgery at all? Let's just go ahead and use ultrasound and place it next to the nerve. That was really the rebirth of peripheral nerve stimulation. Because before that, surgeons really didn't want to be bothered with this big open surgery, and pain physicians didn't have the capacity to go in the operating room and do the type of surgery that was needed to put them in surgically. So Dr. Huntoon was the godfather of making this a portable technique for patients. And so we all do this now. We all place these leads with ultrasound guidance. So he took 30 patients, and he also looked at whether or not they could get a 3 to 7 day trial and then go on to have relief. I will say he also did he also had 8 patients in the trial, and out of the 8 patients in the trial, they all had 60% better pain control 1 year out. All right, so we are excited about this. So what's been happening since then? That was a long time ago. So since then, Richard Rock did 30 patients with post-amputation pain. He placed leads at the femoral nerve and sciatic nerve, which Dr. Trainer and I are going to show you today. This is a very quick procedure. It takes us about 8 to 10 minutes to place it. And the patient keeps it in for about 30 days and then takes it out, 30 to 60 days, and then takes it out. He showed benefits. Dr. Ilfield, which Brooke is going to be talking about later, used the device in many types of operations. So not just shoulders, amputations, bunionectomies. And lastly, Tim Deere recently published a trial that showed across multiple centers that they had long-term outcomes. The data will be discussed with my colleagues. So what about us? So when Gilmore in 2019, when he did a post-amputation study on chronic patients, he placed femoral and sciatic catheters and followed those patients for 1 year. He found very good results as well, and they're going to be discussing the specific data. So our team said, well, what if we put the leads in sooner? And so you're going to hear from Brooke about what happened with that. We put the leads in at 5 to 7 days after surgery, and we're actually looking toward doing a bigger trial. So that's our team that worked on that. So basically, that's kind of the history of this device. I'm sure you're going to hear much more about how the device is is used and where it's used in which areas. And I will just say one more thing, that there are different types of systems. We do all the systems at our facility, so you can ask us questions later about that. The only ones we are not doing at this time are NALU and Mainstay. But we do StimReader, StimWave, and the Sprint device. So those devices are all part of our experience here at the hospital. And with that, I'm going to let Dr. Murphy take over on mechanism of action.
Yes, I'm the RAC medical director at the VA hospital in Richmond. We have, at the hospital, we have a database of over 600 patients with amputations. So we have a lot of experience dealing with patients with phantom limb pain, and we also try to provide guidance up and down the coast where other people are having problems as well. There are a lot of people with refractory phantom limb pain and actually residual limb pain as well. So we welcome any tool that is going to help us manage that. We have found that these peripheral nerve stim devices work quite well for some of the more thornier cases. There's a wide variety of electrical stimulation devices. There's literally over 100, even just the non-implantable types. There's, of course, spinal cord stim and dorsal ganglion stim and other types. And the question is, from a mechanistic point of view, what differentiates the one we use from these others? Why does we implant it for 60 days and then frequently we can get relief, the patient can get relief for up to 6 months, 9 months, 12 months later? And what is the mechanism for that? Next slide. So there's a lot of things you can vary. There's an infinite number of variations you can do with electrical devices. You can vary frequency. Generally, the therapeutic frequency is anywhere from 5 to 150 hertz. You can vary current and power, and some of them have very complex paradigms. So we'll first talk about what is the actual physiological changes that happen with pain. The normal pathway for pain sensation is through the, there's some peripheral stimulus to the mechanoreceptors or thermoreceptors or whatever, and they travel through the afferent pain fibers, which are the A delta and the C fibers, which are transmit slowly, and the smaller synapse in the dorsal horn, and the nociceptive specific neurons and the wide dynamic range neurons. And then these impulses travel to areas in the brainstem and then up to deep structures in the brain, such as the thalamus, the hypothalamus, and then to various cortical structures. There's also various descending pathways. They're inhibitory, GABAergic or glycinergic inhibitory pathways that modify pain. So pain is actually processed at multiple levels in multiple ways. And normally it takes a fair amount of stimulation to activate the pain fibers. But when you have a situation where the nociceptive input is constant and steady, the entire chain of the pain transmission pathway is changed. And there's increased excitability, and there's activation of glial cells and pro-inflammatory molecules. The number of ion channels increases, and there's decrease in the descending inhibition from the pathways from the cortex. There's also changing in the mapping in the brain as well, so that there's actually increased representation for the pain. And so there's an exaggerated response, and it's sort of self-maintaining. The cortical areas, even without peripheral stimulation, can generate pain sensations. So they can develop a certain amount of autonomy. So next slide. So then the question is, how can you modify that whole pathway? And can you, with just a peripheral stimulus, change remote areas from where you're stimulating, such as in the cortex or other areas? And next slide. So they mentioned I think they mentioned this, the Waller-Mills gate theory, which is well known, and sort of at the heart of a lot of these electrical pain devices. And basically, the idea is that you stimulate non-pain fibers, which are the A-beta, A-alpha and A-beta fibers, and you stimulate these selectively. And these fibers have a very strong inhibitory effect on the A-delta and C fibers when they synapse in the spinal cord. So you can block the pain. And so the idea is to stimulate these fibers without stimulating the pain fibers. So there's sort of a therapeutic window for electrical stimulation. Now the problem is that once you stop the stimulation, the pain relief either disappears immediately or else it decays rather rapidly. So then the question is, how do you get around that? And what is the reason for that happening? So we can move on to the next slide. So the part of the idea is that when you're stimulating, either from a surface device or implantable device, usually you use like a paddle or some kind of cuff around the nerve. And the problem is that the stimulation zone or the electrical field decays exponentially from where the a lead is. And actually, only a small percentage of the A-alpha and A-beta fibers get stimulated. So there's a large proportion that are not stimulated. Next slide. Can you do the next slide? So, what the device that we use, what it does is it creates a larger field, so that the field of stimulation from this device is larger, and it crosses the entire cross-section of the nerve, so that it stimulates all or most of these alpha and beta fibers. And that way they get more non-nociceptive pain transmission. And this helps to recondition the central nervous system. But the other thing is that it also, so they can use it for sensory nerves, but you also use it for mixed nerves as well. So in the mixed nerves, they can send out efferent impulses to the muscles. And what this does is it stimulates non-painful muscle contractions. And these non-painful muscle contractions then stimulate sensory proprioceptive signals, such as from the Golgi organs. And this sends more non-nociceptive pain transmission to the brain through the A-alpha and A-beta fibers. So it augments the direct transmission through this indirect pathway. And this conditioning process results in changing the action of the mapping in the brain for the pain, for a hypersensitization, and results in greater pain relief. Next slide. Next slide. So this is just a graphic representation showing that therapeutic window for stimulation of the alpha beta fibers and the pain fibers. So there is a difference in stimulus parameters. Here you have current versus microseconds and versus current versus time. So as long as you stay within the window of stimulating these non-nociceptive pathways, you can recondition the nervous system. Okay, next slide. And we'll skip to the next one after that. Next slide. Oh yeah. So this is sort of the idea of the. So part of the. I mean, obviously this creates a large electrical field which crosses over the nerve, but there are obviously proprietary aspects to this the lead and the stimulation device that that we can't mention. But overall, we found that it to be very effective. Okay, switch on to Dr. Hermansen.
Hi, good morning. Thank you, Dr. Lester. Thank you, Dr. Murphy. Good morning, everyone. My name is John Hermansen. I'm currently a fellow physician on our team studying pain and amputation medicine here in Richmond, Virginia in the United States. Now that we've discussed a little bit about the history and the proposed mechanism of peripheral nerve stimulation and how it may work, it's critical to match this framework with patient selection. This conference is obviously oriented towards phantom limb pain and the amputation population, but let's quickly go over some of the other applications as well. It's important to mention that in addition to phantom limb pain, many amputees also suffer from several of these concurrent comorbidities. Additional patient populations for peripheral nerve stimulation include patients with peripheral nerve injuries, complex regional pain syndrome, both type 1 without the direct nerve injury and type 2 where there is a history of direct nerve injury, cancer pain, nociceptive and neuropathic pain related to stroke, as mentioned earlier. Chronic low back pain may also be amenable to peripheral nerve stimulation, and there are several studies going on in our facility right now. There's literature quoting that up to 80% of transfemoral amputees may have coexisting lower back pain, which is probably not surprising. PNS may also be used in fibromyalgia, and one recent study quoted fibromyalgic symptoms in up to 40% of lower limb amputees. And as previously mentioned, PNS has even been used in Guillain-Barré syndrome for different sources of pain. Many of these populations have developed pain syndromes over a protracted time course. In the case of amputation, severity and duration. Oh, next slide, please. Okay, this actually works. Duration of the initial time of pain and severity of the pain seem to be linked or correlated to the development of the chronic pain. So as has been noted, there's been an attempt to try and control some of these pains early on using these stimulators. Some of the other conditions that we can use these stimulators involve migraines, headaches, occipital nerve stimulation is also quite useful for both of those, including fibromyalgia. Hypoglossal nerve stimulation has been used in cases of sleep apnea. Even tibial nerve stimulation can be useful for an overactive bladder, thought to work by stimulating more proximal and adjacent lumbosacral nerve roots. Even vagus nerve stimulation may be used for a host of different maladies. Next slide, please. Within the amputation population itself, the literature demonstrates that 1/3 to almost 85% of amputees have some form of acute or chronic pain. As we're all painfully aware of, this amputation population is set to double over the next 30 years. So again, a major reason why we're here this year and at this conference. Just some quick figures from the United States alone. Patient populations at up to half of the patients can have chronic pain. Mastectomies number over 100,000 a year in the U.S. Cholecystectomies vary from 300 to 500,000 per year in our country alone. So these are not small numbers, and there are not small numbers of pain, of patients suffering pain from these conditions. Next slide, please. A common contraindication for many procedures is concurrent use of anticoagulation. A benefit of this peripheral nerve stimulator and placement, by virtue of being minimally invasive and typically done under ultrasound, allows avoidance of large blood vessels. Hematomas or device-related bleeding appear to be rare after this procedure and placement of leads, but admittedly data is still scarce. Practitioners in the United States commonly refer to a set of standards as set by the American Society of Regional Anesthesia and Pain Medicine, especially for low and intermediate risk subcategories. High-risk categories include procedures like spinal cord stimulators, both trials and implantation, intrathecal catheters, and vertebral augmentation. So in this setting, PNS and the peripheral nerve affectation normally falls into a low-risk category. Next slide, please. So ultimately, NSAIDs or low-dose aspirin do not appear to be a significant contraindication for the placement of these peripheral nerve stimulators. Clopidogrel is recommended to be stopped 5 to 7 days prior to a low-risk procedure, which again is mostly of what we're discussing. And usually restarted 12 to 24 hours after the completion, barring bleeding complications. IV heparin, they asked to be stopped 2 to 4 hours prior to the procedure. We started approximately 1 hour afterwards. We still have a fair amount of patients using warfarin. And so Nowruz and his group in 2018 stated that in the presence of a therapeutic INR under 3.0, they believe most low-risk procedures should be safe. However, even in this population, they strongly recommend shared decision-making with the treating physician. Low molecular weight heparin, such as enoxaparin, used for prophylactic indications, is recommended to be stopped at least 12 hours prior to the procedure. The injections can be started 4 hours afterwards. When you're dealing with therapeutic dosing, blocks should not be performed concurrently. And in this recommendation, they recommend waiting for at least 24 hours after the last dosing. Thank you. Next slide. And thank you. Next slide, please. I will turn this over to my colleague, Dr. Brooke Trainer, please.
Good morning. My name is Brooke Trainer. I'm one of the anesthesiologists, acute pain physicians, and intensivists that work with this fine group of colleagues here in Richmond, Virginia. So I wear a couple different hats. Acute pain was always my passion, and then I was a military intensivist or critical care air transport anesthesiologist. And so by way of my experience in the military working with critically injured amputee patients, some of these pictures are actually of my own, that inspired me to continue that work in critical care. So that's where some of the innovation and, I guess, different perspective that we see in the ICU has been well translated from my acute pain experience. And being an acute pain physician, I actually, we have this little thing going on in our house where I'm the acute pain doc, and my husband, who's also here today, that's going to be presenting after me, is the chronic pain doc. And so, of course, I think that acute pain is much more important to control early and more effectively, and then they don't have to end up in a chronic pain position where, like this cartoon says, sometimes you just don't know what to do for them, and you send them home with the same problem that they came with. So my goal is to try to prevent them from even showing up in their office so that this doesn't end up being the result for this patient. So again, early and effective acute pain control is called preemptive analgesia. Stop the problem before, prevention before the cure is needed. So the age-old adage, work to prevent the problem. So that's, I think, the goal for acute pain physicians is we want to obtain optimal analgesia at least 48 hours before and during surgery. This has been shown to really decrease the incidence of developing chronic pain over time. And this is regardless, truly it's regardless of whatever modality that you employ, as long as it's effective. So the goal is to find the most effective way to treat this pain up front and early. Regional anesthesia has become vastly used, I think, with the advent of ultrasound and more widely accepted use of it, and training more and more physicians on this technology. It's definitely become more of a mainstay. We would consider it, even in our institution, a gold standard. And there's plenty of studies now out there over the last decade that show that it does alleviate peripheral pain, but does it really do anything for central pain or modifications centrally? That sensitization pathway that Dr. Murphy was discussing, where you have this wind-up phenomenon, is it really effective for what happens in the cortex and in the brain, or even dorsal column level, or is it all just peripheral, modulating the inflammatory response and preventing that nociceptive pathway? So this is why, if we had a perfect solution already, we wouldn't keep exploring, right? So if regional anesthesia, the local anesthetic peripheral nerve catheters were perfect, we wouldn't keep looking, right? So if it's not broken, don't fix it kind of thing. But we realized that they don't work perfectly. So peripheral nerve stimulation, when it came out on the market, it was really exciting because we thought, wow, well, maybe this is our answer. This is something that could be very exciting. We know now that there's theories, we haven't proven it 100%, can't say it with 100% confident, that there is possibility that it can not only work to alleviate peripheral nociceptive input, but possibly even modify or recondition central input. So of course that's debatable. So I'm having the lag in my computer. This is the reason why can you push the next slide? Yeah, the internet is giving some problems here. There we go. Yeah, okay. So traditionally we've used opioids, pharmacologic options, tricyclic antidepressants. The gabapentinoids, really fell into favor. We're falling back a little bit, at least decreasing the doses that we used to think were more effective, because we're seeing complications with pharmacologic options, especially the opioids. I think we all know and have heard of the CDC, pandemic or epidemic. I would say it's a pandemic because it's worldwide, the opioid usage and the harmful effects of what those can lead to, respiratory depression, cognitive impairment, even death. So we're falling, really trying to avoid and mitigate opioids at whatever cost. And so using a lot more perineural local anesthetic catheter-based infusions. This is, like I said, the gold standard at our hospital until peripheral nerve stimulation came around. And so now we're starting to explore, is it even possible to use no medications, to just use a little electricity? So here's a picture of a perineural local anesthetic catheter setup. You go home or in the hospital with this bag of local anesthetic, or you have this ball that you put a bunch of medicine in, and then it's on a timer, or it's on, for a continuous infusion, or it's on a bolus. And you push this button to push this medication along, deliver it through a catheter right around and near the nerve. This obviously uses local anesthetics that are sodium channel blockers, so can have obvious side effects or toxicity risk. So there's a study that recently came out in clinical anesthesiology just in April that showed how advantageous they were, especially in lower extremity amputations. And we've seen the same thing at our hospital. They do reduce the opioid usage among our populations with lower extremity amputations, and it does seem to improve their pain. We can put it in before surgery, so we can give them and offer them preemptive analgesia that's effective. But there's problems with it. So it depends on the user, it depends on the placement, it depends on, whether the patient is, moving around and the catheter becomes dislodged, or whether the nurse is connecting the bag appropriately, or if the connections are loose. And so there's a lot of variabilities that can go awry. And so they looked at this in the European Journal of Vascular and Endovascular Surgery. This was pretty recently done as well, I think 2015. And it was a meta-analysis of the efficacy of perineural local anesthetic catheters after lower limb amputation. And this came out before the article in 2021. And it said that essentially there's really poor quality evidence that shows that the peripheral nerve catheters, the local anesthetic infusions, significantly reduce opioid consumption or effectively control pain. And that really the studies that have been done are poor quality and need to be, you know, improved upon. So better, well-controlled, randomized controlled studies are needed. So you can't really say that this is a perfect system, which is, again, why we are still looking for a better alternative. So what determines the ideal therapy? Of course, you want effective pain control. You want a duration of action that's going to be long enough to get the patient through the acute postoperative pain experience. The worst thing is when we have to pull these catheters out, because our practice is to pull them out 5 to 7 days, which is, I think is actually longer than most institutions. You know, I'm a military physician. We used to put them in for 30 days and keep them in because these patients had so much pain. But that's not widely practiced around the world. In fact, 1 to 3 days, 3 days being average is more common. So 5 to 7 days is you know, at our institution considered pushing the limit in this arena. But we find that, you know, when we take it out, there's sometimes still with 7 out of 10 pain. I don't think that's acceptable. I don't think anyone should be walking around with 7 to 10 pain. So the other risk obviously is the allergic or potentially, you know, systemic toxicity, the buildup of the local anesthetic, or if it inadvertently gets bolused in too quickly, if they disconnect it wrong, if something malfunctions. So there's always the potential for a reaction to occur. A lot of our orthopedic population, not necessarily amputees, but our orthopedic populations with the knees and the hips, our orthopedic surgeons hate local anesthetics because they fall and then they have to come back for a repeat procedure, and it's, you know, lots of paperwork, so nobody wants that. So again, they also complain about the potential, if it's a trauma or something that they repaired to the, you know, femur or the tibial, they fear of the, you know, overarching fear of masking compartment syndrome. I haven't really seen, this is an argument I have with orthopedic surgeons quite often, I haven't really seen this happen, but they have. And they've seen it so much that, you know, at hospitals, they've changed policies to prohibit the use of local anesthetic catheters in patients with the risk of compartment syndrome. And then whether or not these catheters or stimulating catheters are compatible. Even peripheral nerve catheters, there's sometimes a stimulating catheter for placement to confirm placement. And some of them even have like flexibility, and so that has a wire in it to allow flexibility. Peripheral nerve stimulation catheter obviously is a wire with metal in it. So that's the question, if it's MR compatible. And so then, you know, with the catheters, with the local anesthetics, it's absolutely necessary that you have a dedicated on-call acute pain service team to problem shoot these catheters. In the chronic pain world, they don't want to be on call. So absolutely put a catheter in, the stimulating catheter, peripheral nerve stimulator, and you leave it, place it, and forget it, right? They go home with it. You tell the patient how to do it. They call a rep. You don't have to be bothered. So you don't need a dedicated team for peripheral nerve stimulation. So which one is more effective in pain control? I already talked about a little bit about why, you know, there's evidence out there that peripheral local anesthetic catheters are not the best. So this is just more studies that sort of say the same thing that, you know, these other studies have shown. And in fact, in 2003, they did this vast survey. I think it was like 4,000 patients they interviewed in the U.S. About their post-op pain experience, many of them who had had regional anesthesia placed. And it was shocking that 86% of them expressed continued moderate to severe, even extreme pain, despite what, you know, the physicians thought was effective modalities of treatment. So peripheral nerve stimulation, is it a better option? Well, that's what we're studying. So we're, you know, this is a new field, but there is a lot of evidence out there from the spinal cord stimulation trials that have been like decades longer than peripheral nerve stimulation, that neuromodulation is a great opioid alternative in especially this healthcare crisis where we're trying to avoid opioids. So the chronic pain community has seen the benefits of neuromodulation, centrally and with epidural leads. But can it help peripherally? So that's what all the studies are going on now. Dr. Ilfeld is like a huge leader in this arena with all the acute pain trials and studies that he's done in especially orthopedic populations. So a lot of these studies are his colleagues and funding that he's obtained for these trials. But he's looked at total knee arthroplasties, rotator cuffs, ACLs, ankle surgeries, all of them, and they've all shown some benefit, and so it's been very promising. Now, granted, these are all pilot studies, they're proof of concept studies, because again, it's new. So randomized, more larger controlled studies are still needed, multi-center and sham controlled. And there was one that just came out that was a randomized multi-center sham controlled study that was very promising. It just had a low sample size. So infection risk, that's the reason why we take peripheral nerve catheters, the local anesthetic ones, out early, because we're worried that they're going to cause infection, and we definitely don't want infection around a nerve or around an area of operation. Again, too much paperwork for that. It's not good for the patient, obviously. So we take them out after commonly 3 to 5 days. We take them out 5 to 7 days at our institution. But peripheral nerve stimulation, the device that we're going to show you today, is approved for up to 60 days. And there's a coil design of the lead that we'll show you. We'll try to at least show you. It actually is shown to, because of the coil design, that if bacteria were to come from the skin, which oftentimes is the cause of the infection, it would have to travel further to get to the nerve or a problem area. So we really haven't seen it, and there's really also, for fairness, not been a lot of randomized controlled studies to show this either. But what we do have is when the FDA had to approve this device, they had to put this device in about 1,500 patients and show that there was no infection risk. And they did that. And this is a sample of that study. It was 410 patients or catheters that were placed, and there was 0% infection after 60 days. So this is promising. The most common adverse side effect is skin irritation or erythema, probably more from the bandage or the op site that goes over the skin rather than the stimulating catheter itself. So duration, does it matter? Well, we also know that if you take it out when the patient's still having pain, it's not going to work for long-term prevention. So short duration of peripheral nerve blocks or catheters in the early post-op period, 1 to 3 days, is absolutely not effective. That's been shown. It definitely is not effective in preventing the development of chronic pain, but is longer-term management effective. So this is where the military got the idea from. This is a study done in 2010 of keeping these catheters in longer. So there's a group, Borghi et al., that studied putting these catheters in for 30 days. Obviously this is IRB disaster. You don't want to do something that could possibly cause harm. So they had the patient come in every week to see and evaluate the site and make sure that the patient was still safe. And they held the infusion at those visits every week and said, if the patient's still having pain and it's free from infection, then we will turn this catheter back on. And in fact, they went as far as saying if the patient even sensed anything, so not just pain, but the sensation of something there, they wanted to turn it back on. So they kept it for up to 30 days, and that did decrease the incidence of chronic pain. So toxicity and allergic reactions, with the peripheral nerve catheters, infusing local anesthetics, you're infusing a drug. There's obviously the risk for local anesthetic systemic toxicity. It's related to the dose of the drug that's getting into the bloodstream and obviously the timing. So the longer you have it in, the higher risk you have of this building up, and especially if you have comorbidities, patients with comorbidities, liver disease, where they can't really process or break down the lidocaine or the lidocaine derivatives as quickly. And so you have a risk of them potentially developing seizures. So the risk of seizures is obviously increased from peripheral nerve catheters, from inadvertent injection during placement, which is more often when you do see it, or if the infusion somehow builds up to a toxic level. And they did a study, I just thought it was interesting, in 2010, where they measured serum levels of local anesthetics, I guess to try to find the correct dosing. And they did see that a lot of the serum levels were at a toxic range, but in that case, they didn't actually have side effects from it. But it's kind of like crossing your fingers and just hoping. So obviously in peripheral nerve stimulation, there's no medications being infused. So insensate limb, this is, you know, an orthopedic surgeon's fear and nightmare. So they don't like this scenario. So oftentimes, even at our hospital, they don't let us put it around major motor nerves. So like the femoral nerve, if they've had an operation on their leg and they need them to ambulate with rehab or they're going home, they actually don't like it around the femoral nerve at all. So we'll put it around a sensory nerve like the adductor or the saphenous nerve that's in the adductor canal to try to minimize the risk of falls. But then the pain control is not as effective. It's because you're targeting a sensory nerve, but you're not targeting all of them. So it's just partial relief. Whereas in peripheral nerve stimulation, we've only had clinical, anecdotal, because again, Dr. Lester mentioned, we do probably more than anyone in the country right now for peripheral nerve stimulation. So we have seen some patients that have told us they've tripped, especially if they forgot to turn it off before they were, you know, moving from one or exercising from, you know, going upstairs. They actually recommend you to turn off the device before you drive because they don't want you to, you know, move in a position that moves that catheter closer to the nerve and causes it to, you know, get a higher sensation and maybe twitch or you know, trip. So we advise the patient, you know, give them these precautions, warn them about these scenarios, but we haven't really had any adverse sequela where they needed to come back in for, you know, to see the ER or, you know, have an orthopedic surgery from them. But they, you know, there should be probably more randomized controlled data trials for this. Okay. It's lagging again. Okay, did I skip too far? Okay, there we go. So then the compartment syndrome, I won't go into this further. It's pretty much, you know, you experience this obviously if the leg is insensate. You just don't get it insensate limb because it's not, like Dr. Murphy mentioned, it's not really blocking motor. It's stimulating sensory and, you know, alpha fibers and beta fibers, the touch fibers, so proprioception and Golgi fibers. It's not really blocking motor fibers. In fact, if it's blocking motor fibers or activating motor fibers, probably the intensity or the amplitude is too high, and you'll start seeing them with twitching, and that'll be uncomfortable for the patient, so they'll walk it down. That's the other thing that I think is really kind of fun about peripheral nerve stimulation is you can fine-tune it. You can't do that with a local anesthetic. So MRI compatibility. With peripheral nerve catheters, I put no limitation, but that's actually, I need to qualify that. That's if they don't have a stimulating catheter or a, you know, soft catheter that has the wire in there, because then you have the same limitations as you have with the peripheral nerve stimulation. So peripheral nerve stimulation, obviously what you're worried about is the temperature rising in the area of where the catheter is. And so they studied this for MRI conditional approval and showed that, and really there's no metal device that you're ever going to have in a patient that's going to allow for 3 Tesla of MRI. So if the patient has any metal in their body and it's MR conditional, the 1.5 Tesla is what's recommended. So, you know, having said all of these things, going through all of this, I'll let you decide. Is there a better gold standard out there? And so we wanted to know, and Dr. Lester mentioned, like we wanted to know this question and decided to study this. We've been studying it in chronic pain, but we wanted to study it at our institution in phantom limb pain. Specifically, we have a very high, unfortunately, amputation population, which is why we have leaders like Dr. Murphy and Dr. Hermansen, which are, you know, just dedicated to amputee patients. So we've published a feasibility study looking at peripheral nerve stimulation in the acute to subacute period. And so we enrolled 16 patients. We placed 8 in the peripheral nerve stimulator group and allowed them to have the standard medical therapy. We didn't advise or control anything to do with their pharmacologic therapies. And then we allowed the control group to pursue their standard medical therapies as well. Didn't interfere whatsoever with the surgery or the acute pain services plan. And so we consented them, randomized them, and then followed them weekly initially for the first 8 weeks, and then at 3 months, 6 months, and 12 months. And we have here the 3-month data, and we did show reduction in average phantom limb pain and residual limb pain over time. So you can see that in red is the PNS group, the stimulation group, and blue is the control group, and the axis on the left is showing the reduction in pain. So we actually have a 76% reduction at the 8-week mark, so at the conclusion of the therapy, compared to about a 30%, 36% reduction in the control group. And it's even higher in the average residual limb pain group. We looked at opioids and showed that the proportion of subjects using opioids in the peripheral nerve stimulating group was also less. And it was less pretty much throughout. And if you notice, actually, that group started higher. So the peripheral nerve stimulation group actually started at 40% of the subjects using opioids already when they went into surgery. But then quickly after that group, their pain was reduced. And I will also say that sometimes there was a couple patients who had pain, and that was the reason for their amputation, right? You have an ischemic limb or whatever. And so sometimes surgery can reduce that pain as well. But even that being so, look at the marked difference between the groups over time. That sustained itself by 3 months. And I'll just mention, anecdotally, we looked at secondary outcomes. We showed a readmission rate that was decreased in the peripheral nerve stimulation group. We actually had no readmissions, whereas there was over 25% readmission rate in the control group, probably due to pain or other surgical issues. And length of stay, their functional independence measures, so their ability to participate in rehab, their psychosomatic scales, all those really were similar between the groups. So peripheral nerve stimulation, potentially more effective, potentially, we're studying it, can be definitely maintained for longer, 60 days versus 7 days. We believe it's a decreased infection risk due to the coil design. No risk of drug reactions or interactions or allergic reactions. No insensate limb. You can finely tune the pain control with a remote. The patient can do it themselves, in fact. No insensate limb. No need for an on-call dedicated service. And potentially safer in patients with complex comorbidities. So I mentioned liver disease, the breakdown of local anesthetics. Also COPD, we don't like to put local anesthetics around the brachial plexus in COPD patients because of, possibly blocking the phrenic nerve and causing diaphragmatic paralysis. Well, the interesting thing in peripheral nerve stimulation is when we put it in the brachial plexus or the axillary nerve or anywhere, we'd actually stimulate the diaphragmatic nerve. It'd be the opposite effect rather than block it. I don't know if that's an indication for it, but just interesting. Okay, so downsides, it is MRI conditional, but so is, the peripheral, could potentially be the case for the peripheral nerve catheters with local anesthetics. Really can't use it for surgical anesthetic. So that's the other thing. Because it doesn't cause an insensate limb, they would feel surgery. So you still have to, supplement when you're doing surgery with something else. And then the questions that remain unanswered is it going to decrease the incidence of developing chronic pain? There are some studies out there that I'm going to allow my chronic pain colleagues to go through and explain the results of. And then I think for this population, is it also something that could help decrease the time to prosthesis? So effective pain control, we know, could help them get a prosthesis earlier. So with that, I will turn over to my husband, chronic pain physician, Dr. Robert Trainer.
All right, thank you very much. Thanks for having us. And this is, I think, the last piece of talking and then a little bit of a demonstration. So this is all that's keeping us between the break. I'll try to be short. I do appreciate my wife's efforts to try to keep patients from developing chronic pain. It helps us both because I can leave work early, go get the kids. But there are still plenty of work to be done there. And I'm going to show you basically how we approach patients slightly different. But I'll give you a background on what we would do with an average patient. I'll talk a little bit about an average patient, in fact. The historical treatment options will somewhat explain why we do what we do, and then a bit on PNS and some of its limitations that I've found. So plenty of patients, 2 million plus and counting. There's, 20% of patients get better. So it's the majority that live with chronic neuropathic pain, as many of you know, after an amputation. So it will have many psychosocial effects besides patients want to return to work and participate in activities of daily living. This is a big obstacle when they have pain. Pain with the fitting of a prosthesis. Also, our prostheses are getting better and better and better. So we want them to be able to wear them pain-free. That's part of our goal, is not just the pain score, but functionality. So this is a patient I treated, and many had before him had similar, 65-year-old who had a transfemoral amputation for peripheral vascular disease. It was 2 years before I saw the patient, and this is not uncommon. So, unfortunately, we heard a little bit about the mechanisms. There's a peripheral nerve, chronic tonic stimulation. Then there's an effect at the spinal cord level, and then further even at the brain. So some of these changes may be in place, and we're working against a bit of this. Patients will have had their intensive physical therapy, prosthesis fitting. They've probably, before they've seen me, had local anesthetic injections with steroids, Xeomin we're using now. Wearable devices are least invasive to most invasive of how we usually treat these patients. So what are the things that I would offer? Historically, hot radiofrequency ablation, which we define as between 60 to 80 degrees for 90 seconds, has fallen out of favor, as has phenol in alcohol injections. They can lead to a condition called anesthesia dolorosa, one of the hardest to treat. Literally translates as no pain, no feeling with pain. And so there's fiber type switching that's involved as the nerve regrows after complete destruction. So we turn to neuromodulation because we don't want neurodestruction. It has a bad, at 3 to 6 months, nerves grow back, and they grow back worse. So we want neuromodulation. The first iteration really was using that same radiofrequency ablation, but using it in a pulse sense. So at 42 degrees, you don't cause protein denaturation. You don't sever the nerve. You may be able to, as they tout, reprogram it. So there is evidence of CFOS generation, genetic changes that can occur at the spinal cord level with pulse radiofrequency ablation. They've shown, and I'll get into a bit later, the closer you get to the spinal cord, the better that is. So this was an intercostal nerve study, but Cohen et al. Showed treating the nerve was less effective than treating the dorsal root ganglion with pulsed RF. Surgical resections, there are many, and probably more than we can go into in this talk. But they do exist and infrequently used. So what we currently do, besides the one or two on the last slide, we have physical rehab. Doug spoke to you a little bit about the Amputee Center, and they have tremendous resources and options for our patients, mirror therapy being a one that has stuck around. There are, as I said, injections with local anesthetics, steroids and Xeomin, cost less, it's easier to do. Cryoablation is becoming more popular. We're having people have this even before total knee operations. Cryoablation is a basically improvement on a radiofrequency ablation. So where it doesn't tear the nerve, it can create an ice ball that can prevent the nerve from overfiring. And so this is in the United States, it's approved prior to operations, after operations, and so it certainly has a role. It may last up to 3 months. Peripheral nerve stimulation is what we're talking about here. The idea is for it to get to where it works months to years indefinitely. Spinal cord stimulation has been what we've had mostly before peripheral nerve stimulation became what it is today. And it is more expensive, has more invasiveness nature to it. So I'll go through just a few of these. I know it's a very busy slide, and things didn't pop in one by one as planned. But so when we had surgically implanted cuff leads, this was mostly in the hands of the neurosurgeon. And so you had to cut down, try not to injure the nerve, put a cuff electrode around it, then find a place to put the battery. This was an internal battery, so under the skin. Charging that battery was usually a weekly burden. So, that needed some improvement. The first improvement may have gone too fast. So Bion was a injected capsule-like peripheral nerve stimulator, and that went by the occipital nerve. You would wear the battery behind it, and it would communicate with this capsule, which would then deliver electricity. It wasn't anchored in any way. It was in the neck. So some problems ensued. These things migrated all over the place. It was difficult to communicate through the skin without burning the skin to get to this electrode. So even to this day, as we're talking about peripheral nerve stimulation, it's on label or FDA cleared for just about everything except head and neck. And it's a lot of the history comes from that. So now we have, if you want to use peripheral nerve stimulating leads, you would use a tined lead. For a few of the companies offer that. We have, if you can see, the shoulder here has a little patch on it. That's the battery. So the sticker is a battery. This is hard for many of our patients to sort of understand, but that battery will go over the antenna, which is usually on the distal end of any of the leads. And then in their hand is that remote. So that remote will control that sticker, which is the battery, which drives energy into the lead, which now is no longer free floating. These are anchored in and tunneled under the skin superficially, such that that battery will communicate. So that's a permanent peripheral nerve implant. We're using that for many of the same indications you've already heard. The other reversible, approved for up to 60 days use, is something you're going to see in the demo, so I won't talk much about that. Next slide. Next slide. It's coming. But you can see by how often we switch, the Americans have a shorter attention span. We'll try to move it along here. Okay, so whatever you say about the latest and greatest, something being easy is not the reason to put it in. However, being easy to put a device in gives you a lot of data. A lot of people are putting in these reversible peripheral nerve stimulators. They're somewhat easy to place under ultrasound. They don't usually move. If they do, they're easy to replace, so you have consistency. And so it makes it something that you can study, whereas you can imagine one surgeon putting in a cuff electrode might not be the same as a second surgeon putting in a cuff electrode. So the evolution of that one device showed us that the femoral nerve for 30 days is not as good as the femoral and sciatic for 30 days, is not as good as the femoral and sciatic for 60 days. And it's been long enough that now we have 1 year data where even 30 to 60 days can have an effect 1 year out. If you remember, we're talking about, we're just stimulating that peripheral nerve where we know there's changes in the spinal cord, we know there's changes in the brain. So somehow we believe that there's a reorganization. As Doug talked about, if you activate, it's very hard to separate motor from sensory in everything we do. I work now in a trial where we're putting in spinal cord stimulator leads to help spinal cord injury patients walk again. And you really can't separate motor from sensory. So stimulating the alpha afferents can help reorganize a pathway, and then sensory goes along with it. A bit more for a different talk, but the idea of this reorganization, that the way it may work by stimulating something so distal and getting a change all the way at the central neuraxis has to be a reorganization of sorts. Yep. Next slide. And so, this is a bit of the studies we talked about. We got to 12 months relatively quickly with a lead that's placed pretty similar to most folks that are using it across the country. And so we now have data going all the way out to 12 months. Next slide. This is what you'd like to see in a study, right? Time on, 60 days, 2 months, and then that number stays lower. Remember we said, in my chronic pain clinic, 80% will have phantom limb pain, residual limb pain. That's the 20% that don't. So it's very nice to see something that works. This idea of preemptive analgesia has been touted as the answer since the 70s. In animal studies, it works great. In humans, there's been a harder time to prove it, and again, some of that is heterogeneity. So we think, this has a role in just that, preemptive analgesia with prolonged effect. So maybe giving me less patients in the chronic pain clinic. Next slide. So, and I think just hit it one more time, if you would. Yeah. So this is a patient I had just very recently, 2 separate patients. So the first one has the reversible lead. He had hemiplegic shoulder pain, so that what happens, the muscles are weak, the shoulder subluxes, and it pushes right on the axillary nerve. So in this instance, motor stimulation is a good thing because it will actually stimulate the deltoid, lift it off of that axillary nerve, mechanically decrease pain, but also that idea that stimulating motor is also a pathway to stimulate sensory. And so getting better reorganization, the nerve doesn't just feel pain, it now feels a motor stimulation. So the other one, this is this was a trial for a permanent. And so the top part is day 1, and the bottom part is, embarrassingly, day 5. So it migrated quite a bit. This patient had special situation where they already had a spinal cord stimulator of a certain company, so I needed to use that company's device, and it really didn't work. So we're working on other options at the moment, and it'll probably be a dorsal root ganglion stimulator and or a peripheral lead of a different company. All right, we can go to the next slide. So yeah, being prompted to say more. Okay. So yeah, the peripheral leads, they're great. They're the company in order to have it approved, had it in patients for 120 days with no infections. So when it was initially approved for 30 days, we asked them, can you have it approved for 60 days? And they went to our FDA and they were able to do it quite easily. So but there's a limit. Okay, so whereas a permanent, we have obviously placed in the patient. Now it's going to be tunneled under the skin, incision at the lead space, tunnel it back to a battery, which will usually be in the low back area, sometimes in the abdomen if it's a anterior lead. But it's a implanted battery that has a risk of its own infection. In contrast, peripheral nerve stimulators that are placed permanently, they have their own migration rates. The tines are helpful in some sense, but they can still move. And this battery lead communication. So as you saw before, the young woman with the patch on her shoulder, if that's not directly over where the antenna is on the distal end, they won't get stimulation. And so we've had patients even put a tattoo where the battery's supposed to go. It has to be very specific, and so as they've evolved the technologies, it's not perfect. You have to drive energy in without hurting the skin, which means usually a longer wavelength, and then you're limited in the energy you can deliver. The lead fractures can always occur. We have lead fractures that occur with the reversible system, even at 60 days. Lead erosion is another, probably much more common with peripheral nerve stimulators as opposed to spinal cord stimulators. You do have to be close to the skin so that the battery can connect, but if you're too close, lead erosion is a complication that occur even years down the road. So just by illustration, another slightly busy slide, but the important things are in bold. So PNS micro leads came along. They took advantage of the fact that you can stimulate between 20 and 200 milliseconds, stimulate a muscle without causing discomfort. That's different than we had experienced with many other devices. Stimulating a muscle bothers a patient. They don't want the stimulator anymore. They turn it off, throw it away. So now there's a way we figured we can stimulate muscle and it's comfortable. Asymmetric biphasic waveforms, frequencies limited up to 100 hertz. And the amplitude is usually just turn it up until the patient feels it, and then turn it down just 1 or 2 milliamps. Now, spinal cord stimulators today have our regulating agency essentially looks at spinal cord stimulator leads and especially the frequency, and they regulate it as if it's a drug. And so they regulate how high the frequency you can give. And that actually is somewhat makes sense when you think about high frequency can actually shut down nerves, have a local anesthetic-like effect, whereas lower frequencies can actually stimulate muscle. So they do different things with the same lead pattern. So all these, many of these, each company has their own secret sauce, their own mode of stimulation, but each one can offer some unique things more than systems developed just for PNS. So, go back for 1 second. So when we, there has to be a melding of the fields as a point of this, for this column. So when you have a spinal cord stimulator representative using a peripheral nerve stimulator, they use it like a spinal cord stimulator. And it's just a misunderstanding, or they haven't quite caught up with all of the things that PNS is using. And so the two fields actually need to work more together. All right, next slide. So because we had safety data, most of the PNS data is based on stimulation on for 50% of the time, low frequency, less than 30 hertz. So I call this PNS 3.0 for energy optimization. So at the beginning, we talked about how bulky the systems were, how invasive they were, just to have a peripheral nerve stimulator. Then we came up with smaller, better ones that people across the country could use equally, but they may not be using the same energy that they could. And so spinal cord stimulation since 2018 has started using high frequency and having good results with hard to treat conditions. You do have a conduction block at high kilohertz frequencies. And so if you believe that, you know, as we said with peripheral nerve infusing local anesthetics, you want to shut down the nerve. If you keep the nerve shut down, is that enough to change the reorganization pathways? And if it is, then high frequency is what you'd want to use at the periphery as a local anesthetic effect, but for years. If you believe that there's changes at the spinal cord that are not going to be changed by just that, you might want a different pattern. So there's melding of all this, and you know, as I sort of say every day and when I go to work, that I like the collaboration. Acute pain service, chronic pain service, amputee, we work with neurosurgery, we work with spinal cord injury unit. All that brings people together that wouldn't normally have coffee together, and we discuss some of these things. And as the field advances in one area, you can say, hey, why don't you use it in this, and here's how I use it. So, you know, I think that's the next phase for PNS and amputee treatment. So this is the demo part. Yes.
What we're going to do, we want you to get a little taste of what it would be like to put one of these in for a patient. It's very simple. So I'm going to pretend I'm the attending, and Brooke's going to pretend she's my fellow. And we're going to walk through it with you real quick. It doesn't take very long. So basically, I don't know if you can see this well or not, but the system comes with 3 pieces: an introducer and a test lead.
Is this sharing? No, it's not sharing yet. Okay, I'm trying to share our screen with you.
All right.
Share content.
So that's connected, very simply. And then we also have, this is the micro lead. This is what's going to stay in the patient. This little flimsy kind of lead has the ability to send signals to a patient who's holding it in their hand.
Hold on, they can't see you. So see how you work down here.
Oh, okay, work down here. Easy. All right. So let me just show you one more time, the people who are virtual.
Yeah.
Sorry, virtual people. So we have an electrode. Let's see if you can see it here. Over here. Okay. We have an electrode that tests. And then we have an introducer to place the electrode through the skin and toward the nerve. And we'll do that. And then we also have a lead. I don't know if you can see it very well. We're going to place a lead. So traditionally, these patients are going to have a diagnostic nerve injection at some point prior to the procedure. And you're going to want to see about 50% relief. Now, it's debatable as to whether the amount of relief that you see equals the amount of relief you predict with the device, since they're working differently. Local anesthetics with the diagnostic injection work very differently, as both of them already said. When you use electricity, you get more bang for the buck with electricity. So she's going to find her landmarks, her vessels, the femoral artery, the fascia iliaca, and she's going to look for the femoral vein to make sure it's compressible. And this mannequin may not show that. And she'll move down.
Yeah, there's no vein, unfortunately, that
No
you can see
vessels.
because there's no blood flowing.
She's going to walk.
But there's the nerve.
There's the nerve caudally. And we're going to go about 1 centimeter lateral to the transducer in a horizontal fashion. And in plane, place the needle just above. You can go above the nerve, you can go next to the nerve, or you can go under the nerve. So she's going under the nerve there. Beautiful. And then when she's there, I would just connect. And the patient's talking, he's wide awake, there's no sedation. In fact, I did this case with no local anesthetic many times, put a lidocaine patch on their skin 2 hours before, that's it. And we test patient, Tell us when you feel it. Tell us what you like. And they, oh my goodness, I feel it feels great. It covers your pain. Now there's also some. Thank you. There's also some data that says you don't have to get concordant signaling with this device to get good pain relief, because like he said, high frequency stim where it's so fast you don't feel anything. That also has some effect on pain control. And low frequency, we have time to feel something, will also have some effect. So. Then after that's tested, we take out the inside and remove the test. And hold that introducer there. Okay. And we get the actual lead. I'm trying to make sure the virtual people can see that. And we just check the lead, make sure it's not caught up in there. Make sure it's facing the correct way. We warn the patient they're going to feel a pinch, and the lead goes right into the same introducer.
I will say usually I put the ultrasound down, but just for purposes of the demo, like so that I have two hands, I'm going to try to do it with the ultrasound in place. Okay. But you normally wouldn't want to, because you'd want to hold the introducer needle very still.
So once that's attached, we have a little piece, and I'm going to hold this up so you can see it. This is supposed to be skin here. And if you can see this little cradle here attaches directly to the string, and we can test again. Same thing. So now we've tested the lead inside the introducer. Patient is still happy. So this time she's going to get rid of her ultrasound and deploy the lead by putting pressure where she thinks that it is.
So I actually use
the ultrasound. She uses
the
the ultrasound when she does it. Yeah, she
Yeah.
does it differently. And then slowly pull out everything except for the gray and the green together, just leaving the lead in. Pulling everything out at the same time. So it's just kind of like a corkscrew motion, pulling everything out. I'll hold it for you. Pulling everything out, letting the lead kind of suck in as she's pulling it out. And this looks like it takes a long time, but this is really about a 3 or 4 minute procedure in our procedure room. You don't need anesthesia, no surgery, no cut down. Patients can come with your...
And once it's at the
So
edge.
now it's in. You can see it just laying on the skin. And at that time, you can test that again, if you prefer. We're doing a large multi-center trial for back pain with this device, and we're testing again. Yeah, so let's pretend it's going in there.
Okay.
And then we test it again, same thing. We'll just pretend.
Okay.
All right. So basically, once that's in place and we're happy, all we do is put it...
Did you show that?
Yeah, I showed it there.
So it goes in like right at the edge here. Can I see that? Okay. So it would go in there.
Just like that.
And then this would connect
Mm-hmm.
to... Oh, where is it?
Yeah, to this. But basically, before... But basically, we would secure it. I'll show them quick.
Okay.
So this will be on the patient, connected for 60 days. And we put a little bit of hot glue there, a little dressing, and they're done. Patients can change the dressing twice a week if they like. They just can't submerge in a lake or a pool, but they can shower. And sometimes we have patients come back to our clinic if they want someone to help them with the changes. We've done that with sciatic and femoral for some patients. Some patients just need to have sciatic alone. And some people just need to have femoral alone, depending on where their pain is, for their stump or their phantom pain.
And we'll usually put this somewhere where it's not in the way of their, underwear or, so either if they prefer it on their leg or up on their abdomen, just depending on the patient and their body habitus. So, like, stick it on there.
All right. I guess we're ready for any questions you might have.
Can you scoot over?
Thank you very much. And indeed, we have questions from our audience online and also from here in the room. And let's start with a couple of phantom limb pain related questions. And the first question would be, what assessment do you use to measure phantom limb pain and stump pain during your studies?
I'll let
Okay.
Yeah.
So our study, we worked with the amputation clinic. The patients had to have at least 4 out of 10 pain, and it had to be, well, actually, let me start off. For our study, it was a little bit different. Our patients had local anesthetic peripheral nerve catheters for the procedure. So when they first came out of the operating room and we decided to enroll them, they had some amount of local anesthetic effect. So they couldn't be enrolled until after the local anesthetic effect had worn off. We had to demonstrate that with alcohol or pinprick. and they had to have at least 4 out of 10 pain in the missing limb or in the stump to be enrolled into the study.
Okay. Yep.
Thank you. The next one is for the PLP study. How long is the treatment required for in order to maintain the decreased pain?
So which study? Our study?
Yeah, I think the best studies that have shown that have answered that are the ones that have looked at the 12-month data, and that's the study that Dr. Gilmore did, and he demonstrated in his part of the talk, where you see the decreasing trend where the pain started around 6 or 7 when they implanted the device, and this was even in chronic pain patients, who maybe have had experienced this level of pain for a year before they come into the chronic pain clinic. By definition, chronic pain is not chronic pain until it's 3 months old. So they've experienced that level of pain, come into the chronic pain clinic, and then get this device, and in that first, 30 days to even 8 weeks, you see a decreasing trend, and that sustains throughout the level. So even when the device comes out, and we saw this too, unfortunately, when the device comes out, they do experience this like rebound effect where I feel like their pain does bump a little bit right after the device comes out, and they'll say they want the device back, some of them, but it's never at the level where it was to start. So it may be a small bump, and you did see that in Gilmore's study, but then it comes back down, pretty quickly after that and sustains.
And I'll add to that Chris Gilmore, he works with us quite often, and he continues to see those patients up to 4 years in his practice, and there's still many patients in that study that have not had their pain return in 4 years. So I'm waiting for him to publish that data.
Thank you very much. And then we have a couple of questions for Dr. Trainer, especially for the study you were running. And the first one is, what was the control condition in the study you described, and what about the long-term relief?
This is probably me, Dr. Trainer, I guess.
There's two Dr. Trainers.
That's okay. So, and I mean, both of us know enough about each one. So, the acute pain, the standard medical therapy is probably what they're asking, how we compared it, what the control was. So, traditionally, I think this is going to vary from institution to institution, but at our institution, Dr. Lester mentioned that we keep the catheters in for 5 to 7 days. In fact, we place them prior to surgery, so they do have that preemptive analgesia. A lot of these amputee patients are coming in for peripheral vascular disease. I think that was our 70% of our population was there for peripheral vascular disease. And so they have pain pre-existing. And so, we put them in early, keep them for 5 to 7 days. Once they come out, they're on a regimen of gabapentinoids, definitely opioids, and oftentimes we Tylenol around the clock, so scheduled Tylenol. If they don't have kidney disease, which oftentimes they do, we'll prescribe some type of non-steroidal anti-inflammatory that they can schedule. But oftentimes it's Tylenol around the clock, opioids as needed, and gabapentin scheduled. We often prescribe gabapentin, but at very, at low doses. We try not to escalate the gabapentin too high, and then physical therapy and rehab. So,
thank you. And now we have a question directed to Dr. Rob Trainer. One of the result graphs specified improvement for responders, in air quotes. What about all, and here I'm guessing all, including the non-responders?
I knew that would come up.
So that was relating to the graph.
Yeah.
2 months in and then plateau out. Yeah. So.
They didn't really show the in that study. I think that is probably one of the downsides of the study is the non-responders. But the good thing is that it was a very high percentage of responders. I think over 80%. So a lower percentage of non-responders. But we really don't have that data to see where they fell. But essentially, you were a non-responder if you didn't have at least greater than 50% of your pain control. So if you started at an 8, they considered you a responder if your pain fell to a 4. So it's the percentage of your pain reduction that they considered you a responder or not. in that study. And so if it fell by greater than 50%, then you're a responder, and that was higher than 80% of the population. So we're not really sure why the 20 or so percent were non-responders, but it just shows it's not perfect.
Thank you. And the last question, and that is directed to Dr. Murphy. If the mechanisms of PNS is related to the gate control theory, wouldn't the treatment of neuroma, reduced nociception in brackets, have the same effect?
I'm not sure I understand the question. So, I mean, the treatment of neuroma, you mean with the gate control theory, wouldn't that be effective for neuroma? Is that what you're saying?
I think I can translate. I suppose that when you treat the neuroma, you reduce nociception, and so when you stimulate the nerves, you argue that you obviously stimulate the thicker fibers, so you have more of that input, and that attenuates the input of nociception. I believe that was the working hypothesis at the moment.
Right, that's correct, yes.
And so when you treat neuroma, you reduce the input of nociceptive, so it will have a similar effect. Or I guess the question is, how will that compare with treating the neuroma?
I think I can start off, and then if I'm going on the wrong path. So the group Carcanolis that I presented about optimal analgesia basically said it doesn't matter what type of analgesic modality you do, it can prevent as long as it's effective analgesic modality. I think that's what they're getting at. If you do phenol, for example, that Dr. Lester and Dr. Trainer do in the chronic pain clinic, you would think that could potentially change their nociceptive input to the dorsal columns and then possibly cause reconditioning. But what we see is that's not the case. So there was other studies that were done that looked at regional anesthesia as a possible modifier of central sensitization. And peripheral, it definitely works at the peripheral sensitization to decrease inflammatory response, decrease that nociceptive input. I mean, the limb is insensate, or maybe the neuroma taken care of, decreases their pain at the area of pain. But does that modify cortical changes? Does that have any effect on cortical changes? And, according to the gate theory, it should not, right? Because you're not constantly providing some type of stimulus to the alpha beta or A alpha receptors, which is this constant firing of that pathway that should then get to the dorsal columns and then ultimately up the cortical pathways and then reset or recentralize, resensitize, recondition. That's the word. That pathway, because that's not that constant input, whereas peripheral nerve stimulation is that constant input over time. You just surgical resection, neuroma resection, or phenol ablation, or radio frequency ablation, or even local anesthetics just impact at that moment, but they don't give that constant feedback to the central system, which is
and just to add on to that,
go ahead.
And just to add on to that. Just to add on to that, the way we explain it to our fellows is that for years, chronic pain physicians have told their fellows and patients, let's take your pain away. Let's cut that line from where it hurts here from getting to your brain ever. And that might have been a problem. Maybe balancing out the somatosensory cortex with good afferent information versus all negative is actually reconditioning the brain. So radio frequency, phenol, all these things that cut away pain may actually be doing a disservice. Now we want to stimulate, send more information, afferent, good information, and balance the somatosensory cortex with good information. So now you're having this long-term effect that's pain relieving rather than taking it away. We're getting away from radio frequency, kill it, get rid of it, take it out, cut it off. We're getting into give more stimulation to the brain, give more stimulation to the spinal cord.
But it is very tempting to burn the neuroma.
It is tempting.
I mean, it's right
but
there.
It's all free nerve endings. I would never try to stimulate it because it's all free nerve pain fibers. You're sending more of the negative afferent to the somatosensory cortex, and the balance is off again. So my personal opinion would be to try to
treat it first.
Yeah.
So what they say is that the other devices only, like TENS or whatever, certain treatments only stimulate a very small percentage of the A alpha and beta fibers, like up to 8.75%, which is not very much. So because you don't get a large quantity of input from the non-nociceptive fibers, you don't get any chronic pain relief or long-term relief after you stop stimulating. But with the peripheral nerve stim device, you're stimulating virtually all of them. You're greatly augmenting the amount of stimulation from the non-nociceptive fibers. So that's more helpful in retraining like the central systems.
It's a pity you couldn't join us for all the discussions the past 2 days. So there's a lot of rather controversial statements I just made here, but we have another panel discussion this afternoon, and then we can discuss some of those mechanisms.
Yeah,
because we're running out of time.
Yeah, exactly. And I think that is, the disclaimer here is that this is all still new innovation and technology, and a lot of it is founded off of what's been done in the spinal cord stimulation world, right? So it is all debatable, and it's healthy to debate, right? So.
Right. So I guess from our viewpoint as a scientific conference is just to make the disclaimer that a lot of those statements have not been qualified with evidence. So there's still a debate on few of those things. But thank you very much for joining us. Oh, one point, because we work quite a bit on peripheral nerve stimulation. One of the issues, you can raise too much the frequency when you stimulate a peripheral nerve because you kill it. So there's this duty cycle, 40–50% hertz maximum before the peripheral nerve die. So I think that's going to be a challenge for peripheral nerve stimulation going high frequency.
Exactly.
So the safety studies have not, they were done a long time ago on cats, and there's been not much done on the safety of chronic peripheral nerve stimulation at high frequency. But that's a limitation of the technology, but we can talk about that later.
High frequency has got many definitions these days, but yeah.
So above 50, it will be dangerous for chronic stimulation on a peripheral nerve. In the central system is fine, but on the periphery.
Yeah, I think the studies were 70s, 80s when it was below 30, but that technology didn't exist to even test. So,
but it came down to the frequency of activation of the. I mean, the technology hasn't changed that much. They're rectangular pulses, or whatever, but it's still electrical stimulation in a pulse pattern. And the duty cycle seems to be something that if you reduce, then you might be able to increase the frequency of stimulation. But the safety studies have not been done.
Yeah, your point is well taken. In fact, just last week there was something published with ultra low frequency pulses preventing chronic pain. So, quite the opposite. Maybe that's the answer. It's just fields working together, I guess, is the making new friends.
Well, so thank you for joining us. We are going to go for a break now, and for people online, we'll back at 13. Okay, 11:30. Thank you.